students, you all heard of Jimi Hendrix. Jimi Hendrix is perhaps one of the greatest guitarists of all time. The man is so talented that he can play with his right hand, he can play the guitar with his left hand, and sometimes he's even played the guitar upside down. We've all heard his greatest hits that include Machine Gun, Red House, and Bold as Love, and many more. But what makes this man, or what gives this man his out of the world talent? This talent is given to him because of one structure, and that structure is the musician's nerve or the ulnar nerve. Now, because of the presence of ulnar nerve, this man is able to play a 15 minutes devilish solo in Machine Gun, and he is also allowed to play a gracious guitar solo in Red House. So in this session, we'll be talking about this structure that makes Jimi Hendrix one of the greatest guitarists, and that structure is the musician's nerve or the ulnar nerve. So let's understand what is an ulnar nerve, what is the course of ulnar nerve, and what happens during an injury of the ulnar nerve. So now, before going into the course of the ulnar nerve, let's understand where does the ulnar nerve originate from. So we all know that the ulnar nerve originates from the brachial plexus. Now the brachial plexus has nerve roots. These nerve roots are C5, C6, C7, C8 and T1. So the ulnar nerve is mainly formed from the nerve roots C7 partially and mainly C8 and T1. So this C8 and T1 nerve root forms the inferior trunk, and from that inferior trunk the ulnar nerve arises. So from where does the ulnar nerve originate? It is from the terminal branch of the brachial plexus, that is the inferior trunk, and the nerve roots involved are C7, C8 and T1. So these are the nerve roots from which ulnar nerve is derived, and it mainly comes from the inferior trunk of the brachial plexus. Now let's understand the course of the ulnar nerve in the arm. So it's come out of the inferior trunk of the brachial plexus and now it is lying in the arm. So what happens to the ulnar nerve in the arm? So in the arm, around the axilla, it runs in very close proximity to a structure that is the brachial artery. So you also have the brachial artery coming in from the medial aspect of the arm. So this ulnar nerve lies in very close proximity to that brachial artery. And this ulnar nerve runs very close to the medial border of the humerus. So we know that this aspect is the medial border of the humerus. So the ulnar runs at very close proximity to that median border of the humerus. After running downwards, when it arrives 8 centimeters above the elbow, so 8 centimeters above the elbow, after it runs medial to the humerus, it pierces a structure, and that structure is the medial intermuscular septum. So we know that it arises from the brachial plexus, it comes from the inferior trunk, and after coming out near the axilla, it runs along with brachial artery. And we also know that it is running in very close proximity to the medial border of the humerus. Now when it arrives 8 centimeters above the elbow joint, at that point it pierces the intermuscular septum. So you can see here, this is the medial intermuscular septum. So the ulnar nerve, which is running anteriorly, so till it reaches 8 centimeters above the elbow, it is running anteriorly. Now after it pierces the medial intermuscular septum, it goes posteriorly. So it pierces the medial intermuscular septum and it goes from anterior and then it lies posteriorly. So this is the course in the arm. So after it pierces the medial intermuscular septum, it encounters a structure, and that structure is the arcade of Struthers. So let's understand what the arcade of Struthers is. So the arcade of Struthers is a thin fibrous aponeurotic band extending from the medial head of the triceps. So it is a thin aponeurotic band which is coming from the medial head of the triceps and it is getting attached to the medial intermuscular septum. So this ulnar nerve is running underneath the arcade of Struthers. So once it pierces the medial intermuscular septum, after that it runs under the arcade of Struthers, which is an aponeurotic band coming from the medial head of the triceps and getting attached to the medial intermuscular septum. So we should not confuse this arcade of Struthers to another structure that we studied about, that is the ligament of Struthers. So when we studied about the median nerve, we talked about ligament of Struthers. So what is a ligament of Struthers? That is when there is an outpouching or a spur in the distal humerus. From that spur, one ligament comes out, which is the ligament of Struthers. Now, why is it important? Because the median nerve along with the brachial artery runs right under the ligament of Struthers. So sometimes there can be compressive neuropathy by that ligament of Struthers on the median nerve. So when we talk about the median nerve, we talk about ligament of Struthers. But when we talk about the ulnar nerve, we talk about arcade of Struthers. So do not get confused. Whenever we talk about the median nerve and if any compressive neuropathy of the median nerve is occurring, then we talk about ligament of Struthers that is causing that compressive neuropathy. But when we talk about the ulnar nerve, we are talking about this structure, that is the arcade of Struthers, that is present after the medial intermuscular septum, posterior to the arm. So now let's understand the course of the ulnar nerve in the arm. First, the ulnar nerve pierces a structure, and this structure is the medial intermuscular septum. So after it pierces the medial intermuscular septum, it goes underneath another structure here. This structure is the arcade of Struthers. So once it passes the arcade of Struthers, what happens to the ulnar nerve after that? So the ulnar nerve, after passing underneath the arcade of Struthers, goes near the elbow joint. That is, it lies posterior to the medial epicondyle. So you can see in this diagram here, it is now going downwards to the elbow joint, and here it is lying posterior to this structure. So you can see a big bony prominence. This bony prominence is the medial epicondyle, and this nerve is lying right posterior to the medial epicondyle, and in this area the ulnar nerve is very superficial. So if you want to palpate the ulnar nerve at the elbow joint, you simply have to roll your fingers posterior to the medial epicondyle. So if you roll your fingers posterior to the medial epicondyle, you will feel a thready structure, and that is the ulnar nerve. So sometimes you might have encountered that if you have a small trauma to the elbow region, you feel a sudden shock-like sensation of the whole hand. And this shock-like sensation is because of the ulnar nerve. So whenever there is a trauma to the elbow, this ulnar nerve is getting triggered, and because of that, you're getting a shock-like sensation. So any trauma occurring medial to the elbow joint, because the ulnar nerve is superficial, it is lying posterior to the medial epicondyle, and it is very superficial in this area. That is why it is getting triggered, and that is why you get a shock-like sensation. So this part is very superficial. You can feel it. You can roll the nerve as well. Now coming to the ulnar nerve course in the elbow. So once it reaches the elbow joint, it pierces another structure, that is the Osborn fascia, and it is lying posterior to the medial epicondyle. So you can see here, this structure lying posterior to the elbow joint is the Osborn fascia. So the ulnar nerve, once it comes out, so it is lying posterior to the medial epicondyle. After it comes away from the elbow joint, it is now going underneath or piercing the Osborn's fascia. So this Osborn's fascia is also a site where compressive neuropathy of the ulnar nerve can happen. So after piercing the fascia, it runs in another structure called as the cubital tunnel. So very important for us to know that after piercing the Osborn's fascia, it goes to lie in some structure called as the cubital tunnel. So let's find out what is this cubital tunnel. So the cubital tunnel, or also called as the ulnar tunnel, is a fibro-osseous space which is located on the posteromedial aspect of the elbow. So we know that till now, the ulnar nerve has gone posteromedially. It is lying beneath or underneath the medial epicondyle, and after that, it pierces another structure and then comes into the cubital tunnel. Now, this cubital tunnel is a fibro-osseous space, and this transmits the ulnar nerve from the arm into the forearm. So till now, the course of the ulnar nerve was in the arm. After it crosses the cubital tunnel, it goes into the forearm. So this in a way transitions it from the arm to the forearm, and that is the role of the cubital tunnel. So let's understand what is the boundaries of the cubital tunnel. So medially, the medial wall of the cubital tunnel is made up by the medial epicondyle of the humerus. The lateral wall is formed by the olecranon process of the ulna. The floor is by the elbow joint capsule and the MCL, that is the medial collateral ligament of the elbow. And the roof is formed by any ligament that is spanning between the medial epicondyle and the olecranon. So you can see here, this is the cubital tunnel. So in the cubital tunnel, the medial structure is the medial epicondyle. The lateral wall structure is this olecranon process. And the floor is formed by the capsule of the elbow joint and also of the MCL ligament. And the roof is formed by any ligament that is spanning between the medial epicondyle to the olecranon process. So this is the tunnel through which our ulnar nerve is passing, and here it is in the arm. After passing the cubital tunnel, now it is going into the forearm structures. So this is the cubital tunnel, and sometimes this can be a site for compressive neuropathy of the ulnar nerve. Now it's in the elbow. It is slightly distal to the elbow joint, and it runs distally and it pierces in between two heads of the flexor carpi ulnaris. So we've discussed about the ulnar nerve passing through the cubital tunnel. After it passes the cubital tunnel, then it goes between two heads of the flexor carpi ulnaris. So you can see here, this is the ulnar nerve. It's gone its course. It has gone posterior to the medial epicondyle. It has pierced into an Osborn's fascia. It has then gone through the cubital tunnel, and after doing all that, now it is lying between two heads. So this is one head of the flexor carpi ulnaris, and this is the second head of the flexor carpi ulnaris. So the nerve, that is the ulnar nerve, is now going in between these two heads. And the ulnar nerve goes between the two heads and it enters the anterior compartment. So after going in between the two heads of the flexor carpi ulnaris, it is going into the anterior compartment. So till now, the ulnar nerve has not given out any motor or sensory branch. In the whole of the arm, there are no motor or sensory branches given. But in the forearm, it gives out two branches and two branches only. These are the motor supply to the flexor carpi ulnaris. So I told you that in the forearm, after entering the forearm, it is going between the two heads of the flexor carpi ulnaris. While going between those two heads, it is also supplying these two muscles. So the motor supply of the flexor carpi ulnaris is through the ulnar nerve. The second motor supply it gives is the medial half of the flexor digitorum profundus, that is the ring finger and the little finger. We know that flexor digitorum profundus has two types. So it has the medial half and it also has the lateral half. So this medial half is supplying the ring and the little finger. The other two fingers, or the three fingers, are mainly supplied by the lateral half of the FDP. So what is supplying the lateral half FDP? That is being supplied by the median nerve. So this is very important for us to understand that flexor digitorum profundus has a dual supply. The medial half, that is the ring and the little finger, is being supplied by the ulnar nerve. The lateral half of the FDP, that is the rest of the fingers, are being supplied by the median nerve. Now, it runs in a straight line between the flexor carpi ulnaris and FDP. So it runs between the two heads of the flexor carpi ulnaris. After that, it runs in a straight line between the flexor carpi ulnaris and the flexor digitorum profundus. The entire course of the arm, no other branches are given. So afterwards, till it goes till the wrist, it does not give any branches. So from the arm, there are no branches. In the forearm, there are only two branches, that is the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Next, at the forearm, while it is ending, it gives out one branch. So 4 centimeter proximal to the wrist joint, it gives a sensory branch. So let's draw the wrist joint. This is the distal aspect of the ulna, and this is the distal radius. So approximately 4 centimeter from the wrist joint, as the ulnar nerve is coming out from between the flexor carpi ulnaris and the flexor digitorum profundus, at this point it gives out a branch. This branch is the dorsal sensory branch. So that branch is called as a dorsal cutaneous branch, and this branch now goes parallel to the flexor carpi ulnaris. So you know that the flexor carpi ulnaris is also running in this direction. So this dorsal sensory branch is going parallel to the flexor carpi ulnaris, and here there is presence of a bone, and that is the pisiform bone. So after it passes parallel to the flexor carpi ulnaris, the dorsal sensory branch ends by giving a supply to the pisiform bone. So that is the dorsal sensory branch. It runs parallel to the flexor carpi ulnaris and then it attaches into the pisiform bone. So the flexor carpi ulnaris also attaches to the pisiform bone. Even this dorsal sensory branch goes along with it. And what is the function of this dorsal sensory branch? So it is a purely sensory branch which supplies the dorsum, wrist and the hand sensation, and the main branch. So what happens to this main branch? This main branch now goes in continuation. It goes parallel and it lies superficial. So there is presence of a flexor retinaculum in the wrist. So this main branch is going superficial to the flexor retinaculum. So that is what happens near the wrist joint. So 4 centimeters distal to the wrist joint, there is a branch given, and that branch is the dorsal cutaneous branch. This dorsal cutaneous branch goes parallel to the flexor carpi ulnaris and attaches at the pisiform bone. Now the main branch, after giving out the dorsal sensory branch, the main branch goes along the wrist joint, and here it goes superficial to the flexor retinaculum. We know that the median nerve goes under the flexor retinaculum, and that's why if there is any tightening, that forms the carpal tunnel syndrome. But above the flexor retinaculum, one nerve goes, and that is the ulnar nerve. So it goes superficial to the flexor retinaculum. So once it passes through the flexor retinaculum, so here you can see it is passing through the flexor retinaculum, and after that it goes and enters a canal. So this canal, which is present distal to the flexor retinaculum, is called as the Guyon's canal. So the ulnar nerve, after passing the flexor retinaculum, after crossing the wrist joint, enters this Guyon's canal. So what is a Guyon's canal? We've talked about the cubital tunnel that is at the elbow joint. Now at the wrist joint, distal to the wrist joint, the ulnar nerve passes through another structure, that is the Guyon's canal. So let's find out the boundaries of the Guyon's canal. So the roof is formed by the volar carpal ligament. The base, we know that it is passing through this structure, that is the flexor retinaculum. So the base is the flexor retinaculum. Medially, so this area medially, you have the presence of a pisiform bone, which is a carpal bone. And laterally, there is the hamate and the hook of hamate. So the boundaries are: lateral is hamate, medial is pisiform bone, the roof is formed mainly by the volar carpal ligament, and the base is formed by the flexor retinaculum. So if any of these structures get damaged, that can lead to neuropathy at that region, or the Guyon's canal. So if there is a hamate fracture or a pisiform fracture, such cases the Guyon's canal will be compromised, and then there can be an ulnar neuropathy. So it's very important to know the boundaries, because that will help us determine whether there is a compressive neuropathy occurring because of those boundaries being affected. Now in the hand, once it's gone through the Guyon's canal, what does it do in the hand? So after passing the Guyon's canal, the ulnar nerve gives out two very important branches. These branches are the superficial branch and the deep branch. So you can see here, it's gone above the flexor retinaculum. It has passed the structure that is the Guyon's canal, and after that it has given out two branches. This branch here is the deep branch, and the branch that is going straight and forming the digital nerves is the superficial branch. So we have to understand what happens to the superficial branch and what happens to the deep branch. First, we'll talk about the superficial branch. So we know that the deep branch is going perpendicular to the nerve course. The superficial branch is going straight. Many believe that the superficial branch is a purely sensory branch and it only gives out digital nerves, but that is not true. The superficial branch has one motor supply, and that is to the palmaris brevis muscle. So it is, superficial branch is not a pure sensory branch. It gives out majorly sensory branches, but it gives out one motor branch, that is the palmaris brevis. So after it supplies the palmaris brevis, after giving the motor branch to the palmaris brevis, it divides into digital nerves, and these digital nerves are the medial and the lateral digital nerves. They supply 1.5 part of the volar part of the finger. So the volar aspect of the finger, that is 1.5 part of the volar aspect of the finger, is supplied by this superficial branch. So you can see here, this was the deep branch, this is the superficial branch. So this superficial branch will form a medial and a lateral digital nerve, and they will supply this whole little finger and half of the fourth digit. So that is the volar part of these two digits are being supplied by the superficial branch of the ulnar nerve. Now let's understand about the deep branches. So all these hand coordinated movements that we're able to do is because of this deep branch. So let's understand the innervation of these deep branches. The deep branch runs along the deep palmar arch. And first, it supplies all the hypothenar eminences. So you have to understand that there are two eminences in the hand, the thenar eminence and the hypothenar eminence. This thenar eminence, the thicker one, the thenar eminence right at the base of the thumb, is mainly supplied by the median nerve. This hypothenar, the smaller prominence that you see in the ulnar aspect of the hand, that is supplied by the ulnar nerve. So let's understand what are the three muscles that make up this hypothenar eminence. That is the flexor digiti minimi, the opponens digiti minimi, and the abductor digiti minimi. So this aspect of all the hypothenar muscles are supplied by the deep branch. So after supplying this hypothenar eminence, what happens to the deep branch? Now the next muscles that it supplies are the branches to the medial two lumbricals. So this is also important to understand that lumbricals are not completely supplied by the ulnar nerve. There are 4 lumbricals. There are lateral and medial two lumbricals. So the lateral half of the lumbricals are supplied by the median nerve, and the medial two lumbricals are supplied by the ulnar nerve. That is why the function of these fingers are divided between the median and the ulnar nerve. Another thing to remember is that all the interosseous nerves are supplied by the ulnar nerve. So the interosseous muscle that is there is mainly supplied by the ulnar nerve, but the lumbricals, 2 lumbricals are supplied by the ulnar nerve, 2 are supplied by the median nerve. So understand that all of the interossei, both palmar and dorsal interossei, are supplied by the ulnar nerve. So let me simplify that for you. We have presence of interossei, that is palmar and dorsal, and these, all of these are supplied by the ulnar nerve. The same way, lumbricals, there are medial 2 lumbricals and there are lateral lumbricals. So these medial lumbricals are supplied by the ulnar nerve, while the lateral lumbricals are supplied by the median nerve. So this is very important to understand. So after it supplies the lumbricals and then it supplies the interossei, both the palmar and the dorsal interossei, it ends by giving out one very important motor branch, that is, it supplies the adductor pollicis muscle. So we understood that the deep branch first supplies this hypothenar eminence. After it supplies all three muscles of this hypothenar eminence, then it goes and supplies the two lumbricals, that is the medial two lumbricals. After it supplies these two lumbricals, then it supplies the interossei, both the palmar and the volar interossei. So after it supplies both these interossei, then it ends by supplying the adductor pollicis muscle. So that is the course of the deep branch, and it is very important to know the course of the ulnar nerve in the hand, because in the arm it does not give out any branch. In the forearm it only gives out two branches, but in the hand it gives all the muscles. So most of the muscles of the hand, that is the intrinsic muscles of the hand, are supplied by the ulnar nerve. So we know that most of the muscles are supplied by the ulnar nerve. But what are the muscles which are not supplied by the ulnar nerve? So which intrinsic muscles of the hand are not supplied by the ulnar nerve? So a very simple way of remembering this is a mnemonic, that is loaf. So these are the four intrinsic muscles that are not supplied by the ulnar nerve. All of the other muscles in the hand are supplied by purely the ulnar nerve. These four muscles, that is the lateral two lumbricals, the opponens pollicis, abductor pollicis brevis, and the flexor pollicis brevis, are not supplied by the ulnar nerve. So what are these muscles supplied by? So we know that the opponens pollicis, abductor pollicis, and flexor pollicis are actually part of the thenar eminence. So this thenar eminence and the lateral two lumbricals are supplied by the median nerve. So I hope the differentiation is clear. We have to clearly understand which muscles are supplied by the median nerve and which muscles are supplied by the ulnar nerve, because the function of the hand and deformities of hand are different in both these cases. Now let's understand the sensory supply of the ulnar nerve. So first, in the palmar aspect, this hypothenar eminence is supplied by the palmar cutaneous branch. This superficial branch is supplying this distal aspect. So the digital nerves that we talked about, that is the medial and lateral digital nerves, that is a superficial branch, supplies the two fingers in the palmar aspect. In the dorsal aspect, the supply is given purely by one nerve, which is giving its branch out before it comes to the wrist, that is the dorsal cutaneous branch. So this dorsal cutaneous branch gives almost this much area, that is involving 1.5 fingers. So this area is supplied by the dorsal cutaneous branch. So dorsally, the supply of the ulnar nerve is mainly from the dorsal cutaneous branch. Volar or palmar region, it is two ones. One is the superficial branch that is supplying the distal fingers. And then this palmar aspect, that is the hypothenar eminence, is supplied by the palmar cutaneous branch. Now coming to the applied aspects, we've understood the whole course of the ulnar nerve from the brachial plexus all the way up to the fingers. Now let's understand what happens when an ulnar nerve is either injured or there is a compressive neuropathy of the ulnar nerve. To understand the ulnar nerve palsies, we have to understand the tests that are performed for each ulnar nerve palsy. So these tests include an ulnar claw hand, Froment sign, card test, and a Wartenberg sign. So first let's talk about ulnar claw hand. So any patient with an ulnar nerve palsy will present to you with an ulnar claw hand of the 4th and 5th finger. So the hand will look somewhat like this. That is, there is hyperextension at the MCP joint. So you can see here at the MCP joint there is hyperextension, and then look for the IP joint. So in the IP joint, there is flexion. So this appears like a claw hand. So why is this claw hand present in an ulnar nerve palsy? Because the functions of the lumbrical. So normally in a normal functioning hand, the function of a normally functioning lumbrical is flexion at the MCP joint and extension at the IP joint. So if the hand is normal and there is no nerve that is injured, in such a case the lumbricals that are present will help in flexion at the MCP joint and extension at the IP joint. But when there is an ulnar nerve palsy, we know that the medial two lumbricals are weak. So if the lumbricals are weak, this action, that is flexion of MCP and extension at IP joint, is lost. Because that is lost, there are certain antagonistic muscles. So antagonistic muscles are muscles that are acting away or opposite to the action of the normal muscle. So if there is flexion occurring at IP because of one joint, the antagonistic muscle will cause extension because of that IP joint. So this antagonistic muscles will now act more or will be more stronger. Because of that, there will be an increase or a hyperextension at the MCP joint because of these extension or these extensor digiti minimi and the extensor muscles, they are overacting. These antagonistic muscles at the MCP is the extensor muscles. And these extensor muscles will overact and that will cause hyperextension at the MCP. Now same way at the IP joint, because you know that the IP joint extension is lost. That is why the flexor muscles will overact and that will cause flexion at the IP joint and that will lead to clawing. So the ulnar claw hand of the fourth and fifth finger is mainly because the lumbricals of the fourth and fifth finger are weak because of ulnar nerve palsy. Now coming to the second test that we can do, that is a book test. So in a book test, we ask the patient to clench a book or a thick pad, and at the same time, the examiner tries to pull the book away. So you ask the patient to hold a book and same time, you should try to pull that book away from his hand. So when you do that, the patient will try to clench that book or grip that book hard. And this clenching action that is there is mainly done by the adductor pollicis muscle. So we know that the ulnar nerve, the last motor branch that the ulnar nerve gives is the adductor pollicis. And that adductor pollicis is responsible for this movement, that is adduction of the thumb. So whenever you are asking the patient to hold a book, he'll try to clench that book by the adductor pollicis. Now imagine the ulnar nerve is injured. If the ulnar nerve is injured, this action, that is the adduction action of the ulnar nerve, is lost. But we have another muscle, that is the flexor pollicis longus. This flexor pollicis longus is supplied by the median nerve. So if ulnar nerve is injured, the flexor pollicis longus is still working. So in an attempt to hold the book, even in an ulnar nerve palsy patient, he will flex the finger. So his finger will be something like this. In this patient, this sign is called as Froment's positive because here the adductor brevis muscle is not working, but the flexor pollicis longus is working, and that is why patient has an ulnar nerve palsy, and this sign is a Froment positive sign. So you can see here in this normal, when you ask a patient to clench the book, because his adductor pollicis is working, he will clench it normally. But if there is flexion at the IP joint, so here you can see there is flexion of the IP joint of the thumb. This is because the ulnar nerve or the adductor pollicis is not working. But the flexor pollicis longus is working because the median nerve is intact, and that is why he keeps a hand like this. And this is called as a Froment's positive sign. Now coming to the third test, that is a card test. In a card test, you ask the patient to clench onto the card between the fingers. So a card is inserted between two extended fingers and the patient is asked to grasp it between the fingers. And the examiner gently tries to pull the card away. So you can see here, the patient is holding the card in between the two extended fingers and the examiner is trying to pull that card away. So here, the patient should try to adduct those two fingers to hold the card tight. And this adduction between the fingers is done by interossei muscle. So you have to understand that adduction is done by palmar interossei and abduction is done by dorsal interossei. So an easy way of remembering this is pad dab. So palmar interossei is responsible for adduction of the fingers and dorsal interossei is responsible for abduction of the fingers. So when both of these are lost in ulnar nerve palsy, in such cases, patient will not be able to hold the card tight and the card test will be positive. So if there is ulnar nerve palsy, the palmar interossei is lost. If palmar interossei is lost, adduction of the extended finger is lost. Because of that, card test will come out positive. The next is the Wartenberg sign. So when we ask the patient to extend all his fingers and keep it on a firm surface, the little finger stays abducted. So you ask the patient to keep all his fingers extended on a surface. So when you do that, you will notice that the little finger is abducted away from the rest of the fingers. So the rest of the fingers are normal, but the little finger of the affected side is abducted. So why is that like that? Because in ulnar nerve palsy, we know that the interossei are paralyzed. So we know that the interossei is responsible for abduction and adduction. So the palmar is responsible for adduction, the dorsal is responsible for abduction. So if this abduction-adduction movements are lost, in such a case, extensors will act unopposed. So abductors, adductors are lost. So only the extensors of the fingers are working. So when you ask the patient to do an extension movement, the abduction-adduction movement is lost and the extensor muscles are acting unopposed. Now this extensor digiti minimi that is there, so this muscle acting on the extension of the little finger, that normally has a curved path. So it is not a straight path, but it is a curved path like this. So because it is a curved path, this muscle, when it is acting unopposed, that finger will be in abduction. So normally if the interossei was present, it would be normal. But here, because the abductors and adductors are lost and only the extensor is working, the extensor of the little finger is a curved path. That is why it is abducted and the rest of the fingers are normal. And this sign is called as the Wartenberg sign. Now the last sign is the sign of ulnar nerve palsy, that is there will be a loss here or atrophy here. Atrophy or loss of muscle in the first web space dorsally. So dorsally when you see the hand, there will be a loss or an atrophy. Why is this? This is because in that site there is presence of adductor pollicis muscle. And we know that the adductor pollicis muscle is supplied by the ulnar nerve. Now if there is an ulnar nerve palsy, in the long term there will be atrophy of the adductor pollicis muscle. That is why this prominence of the finger or will be atrophied. So there will be an atrophy seen at the first web space dorsally. Now coming to ulnar nerve injuries. So we know that ulnar nerve injuries are of two types. One is a high ulnar nerve palsy and another is a low ulnar nerve palsy. So how will you be able to differentiate between a high ulnar nerve palsy and a low ulnar nerve palsy? So that differentiation can be made out by something called as an ulnar paradox. So we know that in any ulnar nerve palsy there will be clawing. This clawing can be exaggerated or it can be mild. So let's find out in which cases is it mild and in which cases is it exaggerated. So higher the ulnar nerve palsy, lesser is the deformity. So that is an ulnar paradox. So if there is a higher lesion, normally in any nerve injury, if there is a higher lesion, the defect will be more exaggerated. And if the lesion is in the lower area, the deformity will be less exaggerated. But in ulnar nerve, if the deformity is higher, the deformity is less exaggerated. And if the ulnar nerve palsy is in the lower area, then the deformity is more exaggerated. So this is called as the ulnar paradox. And why does this occur? So let's find out. If there is an ulnar nerve injury at the wrist, we know that the flexor digitorum profundus is given out somewhere after the elbow joint. So if there is an ulnar nerve injury at the wrist, the FDP is not affected. So there will be flexion of the DIP and that is why there won't be a prominent clawing. So because the FDP is not affected, there will be flexion of the DIP and hence the clawing is there. Now, that is not prominent. Now same way, if there is an ulnar nerve injury at the elbow, when the injury occurring at the elbow, the FDP is also affected because the FDP branch is given out after the elbow. So if there is an ulnar nerve injury at the elbow, FDP is not working. So there is no flexion of the DIP, and when there is no flexion of the DIP, the claw is not very prominent. So in a case of low ulnar nerve injury, the claw is more prominent, and in the case of high ulnar nerve injury, the claw is less prominent, and this is the paradox. That is, it is different from other nerve presentations. That is why it is called as a ulnar paradox. Now let's talk about the compressive neuropathy. So till now, we've talked about ulnar nerve injuries and all its signs. Now let's talk about the compressive neuropathy. So at what sites can ulnar nerve be compressed, leading to an ulnar neuropathy? So the site starts from the first point we talked about, that is the medial intermuscular septum. So the ulnar nerve pierces through the medial intermuscular septum. So that can be the first compressive neuropathy site. Second is the fascia, that is the struthers, arcade of struthers. That is the second site where the compressive neuropathy can occur. Now the third site is the cubital tunnel. So as it passes through these two structures, goes behind the medial epicondyle, then it goes through the cubital tunnel, and also it goes through the Osborn's fascia. So these two sites also can be the compressive neuropathy sites. Mainly it is the cubital tunnel that causes ulnar nerve neuropathy at the elbow joint, and that is syndrome where the cubital tunnel is causing the compressive neuropathy is called as the cubital tunnel syndrome. There can also be compression at the Osborn's fascia, and after it comes out of the Osborn's fascia, it goes between two heads of the flexor carpi ulnaris. So it can cause a compressive neuropathy even at the flexor carpi ulnaris site. So when there is compressive neuropathy, even in that there will be loss of sensation of the entire hand, and also all of the muscles of the ulnar nerve will be weak. So because of these weak muscles, there will be presence of a partial ulnar claw. So the patient won't be able to do complete movement. So there will be a weak ulnar clawing, and also there will be a loss of sensation of the entire hand. This is seen when there is compressive neuropathy around the elbow joint. Can be a medial intermuscular septum compressive neuropathy. It can be the arcade of struthers. It can also be the cubital tunnel, or it can be the Osborn fascia, or the two heads of the flexor carpi ulnaris. Now distally, there is one site where there is compressive neuropathy. That is, after it passes superficial to the flexor retinaculum, it goes through a tunnel. That small tunnel is called as the Guyon's canal. So at this site, there can be compressive neuropathy. So to understand the causes of compressive neuropathy at Guyon's canal, you have to understand the boundaries. So we know that there is presence of the pisiform bone and the hamate bone medial and lateral to the Guyon's canal. So if there is a fracture of these two bones, that can cause a compressive neuropathy of the Guyon's canal. Also, a lipoma can cause a compressive neuropathy of the Guyon's canal. This usually causes ulnar paralysis of the superficial and the deep branches. So you know that after it passes the Guyon's canal, it gives out a superficial branch, it gives out a deep branch. So when there is compressive neuropathy at the Guyon's canal, in such a case, both your superficial and deep branch is affected. Volar sensations are lost, and hypothenar eminence muscles are lost. So you know that hypothenar muscle is supplied by the deep branch. So that is also lost because deep branch is gone, and even volar sensations are given by these digital branches. Even they are lost because superficial branch is also compressed. But a dorsal sensation is normal. Why is this dorsal sensation normal? Because the dorsal part of the hand is supplied by the dorsal cutaneous branch. And where does the dorsal cutaneous branch arise from? It arises 4 centimeters proximal to the wrist joint. Before it goes superficial to the flexor retinaculum, it gives out one branch, that is a dorsal cutaneous branch. Now, if there is a Guyon's canal compression, that won't involve the dorsal cutaneous branch. That is why the dorsal sensation is normal in a Guyon's canal syndrome. Now let's understand this. So this is the Guyon's canal. So after it passes the Guyon's canal, it gives out a deep branch, it gives out superficial branches. These superficial branches are responsible for the sensation of this aspect, that is a palmar aspect of the hand. And this deep branch supplies the hypothenar eminence and the intraosseous and the lumbricals. Now if the Guyon's canal is compromised, this sensation on the palmar aspect is lost, this hypothenar muscle gets wasted, and the intraosseous and lumbricals are affected. But we have this dorsal cutaneous branch that is going proximal to the Guyans canal, that is not affected, and that is why dorsal sensation is normal in a case of Guyans canal syndrome. So now we've understood the course of the ulnar nerve. After that, we've talked about ulnar nerve injuries, signs of ulnar nerve, and then we've talked about compressive neuropathy. So let's summarize the ulnar nerve. So first is the course of the ulnar nerve. In the arm, it has no significant course. It is running medial to the humerus, and after that, it pierces the medial intermuscular septum, and then it goes underneath the sheath, and then it lies posterior to the medial epicondyle. It pierces the Osborn's fascia and enters the forearm or the elbow. So before it comes into the forearm, it goes through the cubital tunnel. After it passes the cubital tunnel in the forearm, it goes between the two heads of the flexor carpi ulnaris, and that is when it gives out its first two motor branches. In the forearm, it gives out two branches. One is the flexor carpi ulnaris, and second is one half or the medial half of the flexor digitorum profundus. After this, it goes near the wrist and the hand region. So before it goes into the wrist, it gives out the dorsal cutaneous branch. In the wrist, it passes superficial to the flexor retinaculum, goes inside the Guyans canal, then gives out a deep and a superficial branch. The superficial branch gives out one motor palmar brevis branch and then gives out sensory branches to the palmar aspect of the hand, that is the fifth digit and half of the fourth digit. The deep branch supplies the hypothenar muscle. After that, it supplies medial to lumbricals. Then it supplies all four of the interossei, and then it supplies the adductor muscle. So this is the course of the ulnar nerve in the wrist and in the hand. Now coming to the sensory supply. So the sensory supply dorsally is by the dorsal cutaneous branch, and palmar, this aspect, the hypothenar aspect, is supplied by the palmar cutaneous branch, and the fingers are supplied by the medial and lateral digital branches that are arising from the superficial branch. Now coming to the signs of ulnar nerve palsy. So we've talked about the Froment sign, we've talked about the ulnar claw hand, we talked about the Wartenberg sign, and then we also talked about the presence of an ulnar paradox. So in ulnar nerve injuries, we talked about ulnar paradox, where if the higher lesion is present, in such cases the clawing is less prominent, and if it is a lower lesion, the clawing is more prominent. This is because of how the FDP is affected in each of these lesions. Lastly, we talked about compressive neuropathy. So in compressive neuropathy, we talked about the different sites. Mainly, it is the cubital tunnel. It is also the Osborn fascia and the flexor carpi ulnaris in the elbow joint. In the wrist, it is mainly the Guyans canal, which causes a Guyans canal syndrome. So that is about the compressive neuropathies of the ulnar nerve, both in the elbow and in the wrist. Now we've talked about the course and different aspects of injury and compressive neuropathies of the ulnar nerve. That's all for this session.